Dear listeners, this video is part 2 of the 4-part series on ischemic heart disease. For other videos in the series, see Prescribe on Medical Education series, Ischemic Heart Disease. Mechanism of ischemic heart disease, that is pathogenesis. Coronary arterial occlusion. The following sequence of events likely underlies most myocardial infarctions. An atheromatous plaque is eroded or suddenly disrupted by endothelial injury, intraplaque hemorrhage, or mechanical forces, exposing subendothelial collagen and necrotic plaque contents to the blood. Platelets adhere, aggregate, and are activated, releasing thromboxane A2, adenosine diphosphate, and serotonin, causing further platelet aggregation and vasospasm. This leads to activation of coagulation by tissue factor and other mechanisms adds to the growing thrombus. This again leads to, within minutes, the thrombus can evolve to completely occlude the coronary artery lumen. These thrombi are usually at a site that did not previously have a critical, that is more than 70% occlusion, have a critical fixed stenosis. When angiography is performed within 4 hours of the onset of myocardial infarction, it demonstrates coronary thrombosis in almost 90% of cases. However, when angiography is performed 12 to 24 hours after onset of symptoms, evidence of thrombosis is seen in only 60% of patients, even without intervention. Thus, at least some occlusions clear spontaneously through lysis of the thrombus or relaxation of spasm. This sequence of events in a typical myocardial infarction also has therapeutic implications. Early thrombolysis and or angioplasty can be highly successful in limiting the extent of myocardial necrosis. Myocardial infarction without atherothrombosis. In approximately 10% of cases, myocardial infarction occurs in the absence of the typical coronary atherothrombosis. In such situations, other mechanisms may be responsible for the reduced coronary blood flow. Vasospasm, that is blood vessel narrowing due to increased vascular tone, with or without coronary atherosclerosis, perhaps in association with platelet aggregation or due to drug ingestion, that is, for example, cocaine or ephedrine. Another reason, emboli from the left atrium in association with atrial fibrillation, a left-sided mural, that is ventricular wall thrombus, vegetations, that is masses composed of fibrin, platelets, and infecting organisms, held together by agglutinating antibodies produced by the bacteria, vegetations of infective endocarditis, that is IE. And another reason, intracardiac prosthetic material, that is mechanical or tissue walls. Mechanical walls are generally made of titanium and carbon. Tissue walls are made up of human or animal tissue. Or a paradoxical emboli from the right side of the heart or the peripheral veins traversing a patent foramen ovale and into the coronary arteries. Note, a patent foramen ovale is a small flap-like opening in the wall between the right and left upper chambers, that is atria of the heart. Dear listeners, by the way, this educational video is made possible by Prescribe on, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribeon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Myocardial response. Coronary arterial obstruction diminishes blood flow to a region of myocardium, causing ischemia, rapid myocardial dysfunction, and eventually, with prolonged vascular compromise, myocyte death. The anatomic region supplied by that artery is referred to as the area at risk. The outcome depends predominantly on the severity and duration of flow deprivation. The early biochemical consequences of myocardial ischemia is the cessation of aerobic metabolism within seconds, that is ATP deprivation, that is adenosine triphosphate, loss of contractility within less than 2 minutes, irreversible cell injury in 20 to 40 minutes, and accumulation of potentially noxious metabolites, example lactic acid. Because of the exquisite dependence of myocardial function on oxygen and nutrients, myocardial contractility ceases within a minute or so of the onset of severe ischemia. Such loss of function contributes to decreased systolic function long before myocyte death occurs. These early manifestations of ischemic injury are potentially reversible. Only severe ischemia, blood flow 10% or less of normal, lasting 20 to 30 minutes or longer, leads to irreversible damage, that is necrosis of cardiac myocytes. This delay in the onset of permanent myocardial injury provides the rationale for rapid diagnosis in acute myocardial infarction to permit early coronary intervention to establish reperfusion and salvage as much at-risk myocardium as possible. The earliest detectable feature of myocyte necrosis is disruption of the integrity of the sarcolemmal membrane, that is the cell membrane, allowing intracellular macromolecules to leak out of necrotic cells into the cardiac interstitium, that is the space between heart cells, and ultimately into the microvasculature and lymphatics. This escape of intracellular myocardial proteins into the circulation forms the basis for blood tests that can sensitively detect irreversible myocyte damage and are important for managing myocardial infarction. With prolonged severe ischemia, injury to the microvasculature, that is minute blood vessels, follows injury to the cardiac myocytes. The upper pictures in this figure shows progression of myocardial necrosis after coronary artery occlusion. The so-called area at risk near the apex is shown clearly. The bottom picture series show the stage of infarct at 0 hour, 2 hours and 24 hours. At 0 hours, the zone of perfusion is shown, that is the area at risk. At 2 and 24 hours, the zone of necrosis is clearly defined. The area has become pale after the complete infarct. The progression of ischemic necrosis. The progression of ischemic necrosis in the myocardium is summarized in the figure shown earlier, that is, in the progression of myocardial necrosis. Irreversible injury of ischemic myocytes first occurs in the subendocardial zone. This region is especially susceptible to ischemia because it is the last area to receive blood delivered by the epicardial vessels, and also because it is exposed to relatively high intramural, that is intraventricular pressures, which act to impede the inflow of blood. With more prolonged ischemia, a wavefront of cell death moves through other regions of the myocardium, driven by progressive tissue edema and myocardial derived reactive oxygen species and inflammatory cytokines, that is mediators. The location, size, and specific morphologic features of an acute MI depend on the following. Location. The bigger the vessel, the larger the area affected. Severity. The more severe the cross-sectional area of obstruction, the more severe the damage to heart muscle cells. And rate. Rapidity of development of coronary obstructions due to atherosclerosis and thrombosis. The size of the vascular bed perfused by the obstructed vessels. The duration of the occlusion. The metabolic and oxygen needs of the myocardium at risk. The extent of vascular collateralization, that is naturally developed parallel network of blood vessels. The presence, site and severity of coronary arterial spasm. An infarct usually achieves its full extent within 3 to 6 hours. In the absence of intervention, an infarct caused by occlusion of an epicardial vessel can involve the entire wall thickness, that is called a transmural infarct. Clinical intervention within this critical window of time can lessen the size of the infarct within the territory at risk. Dear listeners, this is the end of part 2 in this 4-part series on ischemic heart disease. For other videos in this series, see Prescribe on Medical Education series Ischemic Heart Disease.